At the end of last year and the beginning of this year, the Missoula City County Health Department produced 3 special reports, and the Board of Health took part in a strategic planning process that's just concluding. One result of all this recent reflection on public health in Missoula has been a request for a presentation of some of the highlights of this work, a status update. Presenting today will be 2 speakers, Ellen Leahy, the Director and Health Officer of the Missoula City County Health Department, and Greg Oliver, the Health Promotion Director, also at the Health Department. What you're looking at here is the Higgins Avenue Bridge in the 1930s. Strategies to protect public health have accumulated over the last 200 years, one hard-earned step after another. This report consists of 2 main sections. One that looks back and considers public health as a whole, and one that sketches where we stand now. Ellen will talk about the portion that looks back and under the public health overview, and then Greg will briefly look at a number of different components of public health and Missoula's relative status. Then Ellen will return and talk about some emerging concerns. If you want more information about these topics or anything else on public health, there are 2 good places to look. One is a website called Missoula Measures. It'll take a moment for you to copy that down if you're interested. That's the county website that's mentioned there, and you can find your way to the measures. And another is a report, a special report that came out in November called Public Health in Missoula 2000, of which there are hard copies available.
In order to provide a context for what we're going to talk about today, we're going to take a quick look at what public health is and how it works. We'll take a look at the history of public health, how we got to where we are today, and a little bit about the nature of that history and how some of those factors that created our history still play out today. Greg will then go on to what we call our vital signs, how we're faring today in public health, and just a glimpse at the future that we can see from here. What public health is supposed to do, or its mission statement, is to fulfill society's interest in assuring conditions in which people can be healthy. And I think the key words in this mission statement are assuring certain conditions. It is the sanitary conditions, environmental conditions, conditions of nutrition, those types of things that actually have an effect on the overall public health. And what this mission statement recognizes, I think, is the fact that public health lives at the intersection of societal interests, societal and cultural behaviors, science, all of those things that have to do with the day-to-day aspects of our lives. I think, however, an easier picture to imagine when thinking about the public health system is to just think of it as the population's immune system. Just like an individual's immune system, it is supposed to be vigilant, always looking for threats for that organism. If a threat emerges, the immune system is supposed to respond quickly. It's supposed to learn and form long-term protections against that threat in the future. And just like our immune system, our public health system can sometimes cause negative symptoms when it's working, and it is often mostly silent when it's working. And certainly if we let our immune system become weakened, then things that wouldn't otherwise be a threat could actually decimate our system. And so that's probably, in my mind, the best picture a person can conjure up about public health. One of the fundamental societal values, or the underpinnings of public health from its beginning, is the assumption or the belief that society does place a value on prevention. There's many ways to state it. One of my favorite is Florence Nightingale's quote of long ago that preventable disease should be looked on as a social crime. Again, I think this recognizes the social aspects that affect public health and vice versa. Public health in the United States, in the system as we now recognize it, which is a more permanent system, got its start really in New York City. Before the cities emerged as urban centers, there were temporary health boards and temporary health responses in the colonies. An epidemic would happen, and there would be a temporary response, and then whatever that committee or board was would go away until the next problem came up. But as we began importing folks for a workforce, as we began industrialization, immigration, and all the aspects of urbanization, we began to learn that it was smarter not to just respond when issues came up. And like an immune system, we tried to form a long-term response to prevent problems. We really had to do this because the effects of urbanization brought with it poor nutrition, poor living conditions, sanitary problems that had to do with not having the right infrastructure to drain away waste, problems with clean drinking water, and of course mixing one population of folks that may have been exposed to a disease with another population that weren't. So this is a picture of Ellis Island in the 1800s. And one of the first steps in permanent public health development was the whole notion that you could stop disease at the borders. It's a notion that has pretty much been given way to better methods of prevention, and the fact that we now have new diseases that aren't necessarily caused by communicable disease. However, in the early stages, this is Ellis Island, was the idea that we could stop disease at the borders. But we soon learned in New York City that that wasn't enough, because even if quarantine and screening happened at Ellis Island and in the other maritime borders of the country, we saw that some of the effects of urbanization right in the city were troublesome and causing poor health. And in particular, there were 3 waves of Asiatic cholera that really decimated some of the populations of New York City. And after the first one, some of the people that became public health reformers decided that we really should prepare and prevent the effects of the next one. This is a quote from one of those premier public health reformers, Stephen Smith, who started the Public Health Association, the American Public Health Association. And what he's recognizing here is that amongst all the city workers, and there was quite a number at the time, there were none whose job it was to take note of disease. Some worked on streets, some worked on other issues, but he said that not one feels required of him to take note of or use any effort to check the immense amount of disease. And I think this statement really leads to the whole concept of public health, that the system is supposed to exercise vigilance. The tool that we use in public health for vigilance is called epidemiology. It's a scientific tool. It has a range of measures that can be taken. Its official definition is a science that deals with the incident, distribution, and control of disease in a population. What it really does is it looks for patterns. And if patterns are identified, then we try to test what are the factors that might be causing disease, and then the next step are what are the factors that could prevent disease. Probably an easier way to understand it is to look at a recent, well, let me back up here. The whole concept of epidemiology has been credited to a gentleman in London around the times of cholera, again, about the same time that New York City was forming. So in the this was about 1864, there was a cholera epidemic in London. And if you look at the blue color here on our map, this is Golden Square in London, you'll see that it marks a pump. It was called the Broad Street Pump. And this gentleman, John Snow, felt that there was a pattern to the way the cases of cholera were emerging. And what he did is he went around and interviewed people, what we now call shoe leather epidemiology. And he interviewed people in all those places marked in red. And the people in those places now marked in red had consumed water from the Broad Street Pump. The leaders of the time that were looking at the epidemic believed that the epidemic was caused by a number of meteorological factors, and not the factors that John Snow identified. But history proved him to be right, and he is credited as being the father of epidemiology. So there's an old example how epidemiology worked. A more modern one is an example here in Missoula. Back in 1995, we had an E. coli outbreak, and I think people are probably aware that E. coli is most often found in undercooked meat. But we used the methods of epidemiology, the interviewing methods, contacts and tracing, and also the environmental methods that we have learned. And we early discovered that we weren't seeing a pattern that really included meat. It didn't exclude it, but it didn't necessarily include it. And it was through that we were then able to take the next step, which is to generate a hypothesis that it was produce. And from there, with help from the Centers for Disease Control, we participated in a very rigorous form of epidemiology called the case control study, in which we were able to demonstrate that, in fact, the E. coli came from lettuce. The science, now that it's developed, looks pretty matter-of-fact and seems rather accepted today. However, putting the science to work and putting a permanent system in place to use this type of science and exercise this vigilance and take protective measures has never been easy, and it isn't today. And this is one of my favorite quotes. Back in New York City again, they understood how to protect from cholera. There were reformers like Stephen Smith who wanted to protect from cholera, but the mayor was pretty threatened by the notion of a health board, someone that would issue orders other than the mayor. And he said, I will not call the health board, for I consider it more dangerous to the city than cholera. And I think that this exemplifies for us that in a free society, particularly in a free society, the whole idea of setting measures on people's behavior, even if it's to protect the overall public good, is always a very precarious balancing point. However, the diseases of the time were extremely compelling. Here's a group of public health workers whose job it was to trap rats to prevent bubonic plague in a southern part of the country. A very frightening disease. And here's a group of public health nurses taking a bit of a rest in an outpost. They're fighting yellow fever. We spent well over a century fighting yellow fever, not really knowing what caused it, but being able to implicate some measures. So these types of very compelling diseases in a developing nation helped the public begin to demand some sort of protection, and that gave the state a more compelling interest to establish the public health system largely as we know it today. The same kinds of triggers were in place in Montana over 100 years later as Montana was developing, and shortly after it reached statehood, it still did not have a state health board. And finally, after 3 years of a raging smallpox epidemic, one that really got loose in Great Falls and became known in places across the nation as Montana fever for lack of the necessary permanent precautions that should be in place to prevent epidemics, we then got our state health board in 1901. And these are the headlines from the Great Falls Tribune that actually were the turning point in saying, yes, we do have smallpox and we do need to take preventive measures. This is a copy of the petition of all of the urban areas or the developing areas of the time, Butte, Missoula, Great Falls, Anaconda, asking the governor to please do something so that they could put a public health measure in to try to deal with the raging epidemic of smallpox. And again, that seems so very easy and so very plain for us now, but there were many more signatures collected on petitions against the creation of such a board. Nevertheless, the board was created, and public health did become more of a permanent methodology in the state, and at the time used a lot of the methods, again, at the time. And here's a picture, a rather colorful picture of a gentleman in the pest house in Butte, Montana. We didn't have antibiotics, we didn't have vaccine, we didn't have some of the measures that we have today, and so we tried to stop disease by quarantining folks. And Butte was particularly well known for being very vigilant about disease. Certainly they were undergoing a lot of urbanization. So much of our state's public health actually came out of Butte. Public health in the early years of Montana had what were some of the more traditional, what today are more traditional measures to protect the public health. At the time, issues like typhoid were very, very important. People used privies, and again, we had urban centers, but we didn't have the infrastructure to provide sanitation. So this was kind of a common type of public health poster and warning at the time. Somewhere on here it actually says the flies in your privy will be in your dining room this afternoon or this evening. Many public health improvements have been made in most areas of the country, but there are places where poverty still allows sanitation issues to be in place, to be less than adequate. Another early and continuing measure of public health is advancing the health of mothers, babies, and children. And public health nurses, again arising out of New York City in the late 1800s, began visiting nurses and instructive and home visiting programs. So both our sanitation issues and our maternal child health issues and our communicable disease issues are still in place. One of the biggest advances or watershed periods for public health was the recognition of the role that microorganisms took in causing disease. And this is the TB bacillus, recognized by Cook in 1882, and for the next decade or so, science, epidemiology, and certainly public health advanced considerably, because now we could use a much keener and more focused approach to stopping the spread of disease because we knew what we were dealing with. These advancements really emboldened public health. We're back in New York City again, and this is after Cook has identified the TB bacillus, certainly after Pasteur's reports. And the public health officer at the time stated something that remains in public health history today, and that is the notion that public health is purchasable, that a community can determine its own death rate. And what he's referring to is we know how to prevent the epidemics and the causes of ill health, and if we make the right investment, we can do so. Our work in preventing communicable disease got even keener over the years with the advancement, the development, and distribution of antibiotics. We still had some social concerns about how we might advance the information we had, and certainly this is a good example. It wasn't always in our history that we could talk about or put billboards up about gonorrhea and getting your penicillin shot. This was during the World War II, however, and that seemed acceptable and in fact necessary at the time. So just below our buy bonds notice here, we have get your shot for gonorrhea. But the main point here is that we didn't have to use quarantine measures on a lot of diseases once we were able to curb them with antibiotics. And probably our most touted public health advancement was the use of vaccine. And the use of polio vaccine is probably the one in the most recent memory. But with vaccines against diphtheria, smallpox, and then eventually polio in the 50s, we were able to take scenes like this. These are all children in iron lungs affected by polio, and make them into scenes like this. These are kids that just got their polio vaccine. So we really did a lot with preventing communicable disease. And there's one other quick little Montana picture I think it's fun to know about. This is a picture of someone inspecting sheep herders in Montana for tick bites. And the entire story of Rocky Mountain spotted fever really takes place in Ravalli and Missoula counties. And it was one of the first things that our new state health board worked on. It was a real killer at the time. It killed 70% of the people that it infected here in our area of the state. And again, science, society, policymakers, and public health, and the public came together to make that not the type of problem today that it was then. Another more unique and more recent piece of our history Missoula was the first locality in the United States to have restrictions on wood stoves, and most Missoulians are familiar with the real problems we had with air pollution from wood stoves. And while that seems like an accepted value today, it was not simple at the time. Once again, we were dealing with personal liberties and the health of the public as a whole. And this is the first day that the wood stove regulations were in effect, and we have a gentleman here letting a county commissioner know what he thinks about those. So a part of public health is working with society and society working with it to change values. Well, has it worked? Has this history brought some gains? Oh, excuse me, there's one other point. We've also learned more about our environment. We've learned more about not just protecting against contamination at the point of consumption, but protecting our resources as well. And this quote from our own local professor at U of M, Bill Woosner, about how we use the top of our aquifer as an open sewer to dispose our waste into and assume that the bottom will be clean enough to drink. We are wrong. I think is a real landmark quote as we began to look at not only how to protect our resources, but how to look at issues other than just microbial contamination and to look at chemical contaminants. So again, I ask the question, has all this history worked? This is a chart of the infant mortality rate from the 1850s to the 1990s, and some believe that infant mortality is the most sensitive measure of public health and a society's willingness to protect public health, and I think we've made a lot of gains here, as you can see. And this is our life expectancy over the last couple of centuries, and you can see that we've had huge gains. In fact, in just the last century, we've added 30 years to the average life expectancy. If you're wondering what that big nadir is there in the middle, that's actually the 1918 flu epidemic was so devastating in the world and the country that it actually changed life expectancy during that time. So overall, however, we've added 30 years to our life expectancy. But in doing so, we've really changed the picture of disease. We haven't wiped out ill health. We've taken the causes of death as they appeared in the 1900s, the early 1900s, which had a lot to do with infectious and communicable disease. And we now see that the causes of death, and here we're looking at the causes of premature death as well, have more to do with lifestyle and chronic disease, heart disease, cancer, stroke, pulmonary diseases. And you'll see our infectious diseases lower on the column. But we also know from HIV that they can still arise. We know that TB continues to be a problem. So they aren't gone, but our prevalence of disease in that picture has changed. With that, it's time to look at where we are today and what are our vital signs or causes of ill health today.
Well, we'll move into looking at how we're doing today on a number of the concerns that Ellen just mentioned. One of the challenges is that each of the topics that follow could easily by themselves fill an hour presentation, so this is going to be a brief look, a brief glance, but at least it sketches out the territory of public health. And one of the challenges with public health is the breadth of the field. What I'd like to do is give a brief introduction to each of the concerns that follow, talk a little bit about what we've called a vital sign or an indicator that shows how we're currently doing, and then glance ahead and talk about a few of the things that we think that we'll be working on in the future. This picture is associated with a mumps quarantine in the early 1900s. Many people think that the reduction in cases of infectious diseases is regarded as the most significant public health achievement in the past 100 years. Ellen mentioned some of the reasons for the great success that we've had. I'm going to restate them. One is the improvements in basic hygiene, improvements in food production and handling, improvements in water and sewage treatment, and then, of course, antimicrobial drugs and vaccines have all helped us reduce infectious diseases. Currently in Montana state law, there are 57 reportable communicable diseases that the health department has a responsibility to respond to, and actually respond to in different ways. Despite the progress that we've made with infectious diseases, they're still a major cause of illnesses and death. And interesting enough, most all of the diseases never go away completely, and then frequently some return. And one of the concerns that public health people have been talking about lately is the increasing resistance to antibiotics, that our antibiotic strategy may break down in the future. So a health department needs to do a few things in order to be ready to respond to these 57 diseases. We need an effective surveillance system so that we find the cases as early as possible and recognize what they are. Ellen talked about epidemiology, and we have to do an analysis to try to figure out what the source of those cases are. And then there's individual case and outbreak response. In addition to that, there's ongoing education, there are prevention programs for different diseases like HIV, and there are immunizations for our children. I'm going to talk about 3 concerns that are currently on our communicable disease plate. And the first has to do with sexually transmitted diseases. In the 1980s, there were about 5 STDs that we regularly monitored and watched. There are more than 50 recognized now. So some of our diagnostic procedures have allowed us to actually discover a lot more sexually transmitted diseases. One of those diseases is chlamydia, which is fairly common in Missoula, and this gives you a sense of the trend. It's essentially been climbing again after dipping for a while, and this graph doesn't represent the males that have been cases for the most part. For the most part, this is just female cases, because often males are treated as contacts and they're never cultured, so they don't officially become numbers. Another disease that is causing us a lot of concern is hepatitis C. There are lots of different kinds of hepatitis, which just means that there's an infection of the liver, and one of the agents is hepatitis C. It's apparently been around a long time, but we didn't have the ability to diagnose it, and now that we do, we find that many people are carrying this virus in a kind of chronic condition. It's a lifelong infection. Its symptoms are vague and may take years to develop. It's primarily bloodborne. Many of the cases that are being identified now are the result of blood transfusions or injection drug use, the sharing of syringes. We've had in 1996, probably it was about the initial time that we were catching some of these cases, we had 23 reports, and we had 100 reports in the year 2000, and it's one of these things that many people don't know that they have. And then a disease that was mentioned in Ellen's presentation that's really rather ancient and has been a challenge for mankind for a long time is one of the diseases that's making a reappearance with drug resistance, and it makes the nature and the quality of our response much more critical to make sure that when we find cases that we treat them appropriately so that we stop the disease. There's about 2 to 3 new cases a year in Missoula, and they're incredibly challenging for us in terms of intensive follow-up. Management over 6 to 9 months that's at least once a week, and sometimes more often than that with individuals that aren't, well, let's say, as enthusiastic about following their drug regime. A perennial concern in Missoula is our air quality. We've been concerned about it for decades, and probably many of you viewers know that there's been an incredible amount of response to it. Ellen pointed out several of the stages of that response. This photo shows a teepee burner, which used to be more common in Missoula into the 60s. In 1967, Montana passed a Clean Air Act, and then in 1969, the health department was able to establish a local program that gave us responsibility to oversee the state of Missoula's air quality and allow us to do the kinds of things that we've been doing since then in working to reduce air pollution. The two main pollutants that we pay attention to here are particulate and carbon monoxide. On poor air quality days, there are very small particles, 10 microns in size or less, that are suspended in the air that makes it appear dirty or hazy. Particulate matter is composed of dust, soot, and other compounds. The amount of particulate in the air is measured as micrograms per cubic meter. And this slide shows you the standard that is established by the Federal Clean Air Act that we're supposed to maintain with particulate over a 24-hour period. The good news is that we've made great progress with all of our strategies over the year and see a steadily declining line in this graph. There's just been a major amount of community work and decision-making and changes that have led to that. Though our air is at times far from clean and sometimes is polluted enough to still constitute a health hazard, we think that we're making a good difference with air quality. When you look ahead, you still recognize that there are times, especially in the winter, in which our air is far from clean. We have an increasing population and a limited air shed, and that's going to just continually challenge us. We have an increasing vehicle miles traveled, and we have more people coming into Missoula driving, and that's a major source of air pollution. Nationally and in Missoula, we're seeing asthma increasing. This is a concern that we have. And then there are requirements with our relationship with the federal government as far as our status in terms of pollutants that we need to work on in terms of redesignation and changing it to a maintenance status. Ellen also talked about another core public health activity, maternal-child health. This has been at the heart of public health right from the early stages. Ellen mentioned that preventing infant mortality is a key goal of maternal-child health, and just improving the health and well-being of children and families in general. We do many things in the maternal-child health field. Some of our key efforts involve a neighborhood nursing program in which nurses get to know particular areas of Missoula County and visit people in their homes and assist them with various things. There's a public health clinic that provides immunizations, and there's a host of special programs dealing with exposure to lead, health and child care issues, and increasing the number of kids that have health insurance. So an indicator that's somewhat related to infant mortality is low birth weight. And low birth weight infants include babies that are born too early and babies who suffer retarded intrauterine growth. A low birth weight baby is a baby that weighs less than 5 pounds, 8 ounces. Low birth weight is a useful short-term measure because of the strong relationship between birth weight and infant mortality and disease. Low birth weight is also a good long-term measure, as these babies are at much higher risk for a host of developmental and physical problems as they grow older. And then birth weight also sheds some light on the status of our overall system that supports children and mothers, and it reflects the interrelated community issues such as socioeconomic status, race, maternal age, education, access to health care, and the use of tobacco, alcohol, and other drugs. So here's a chart of where we stand in terms of low birth weight. We've been relatively steady for the last 10 years in particular, averaging around 6% of our babies falling into that category. As far as infant mortality goes, over a 4-year period, or 5-year period in the early 90s, we averaged about 8 deaths per 1,000 births. There is something in public health called the Healthy People 2010 goals that give us targets for all of the local public health communities to go for. The goal for low birth weight is about 5%, so we're just 1% over that right now. Another concern that I decided to talk about in maternal child health, but that we could probably talk about in any of the topics that are related to public health, is poverty. Our department does not have the charge to work on poverty itself, but we work on health concerns, and what we notice is that in every health concern, the experience of poverty is related to some of the outcomes that we're looking at. Almost every positive personal and community outcome is negatively affected by poverty, including short and long-term health. And this brings up another concept that I think Ellen will visit towards the end, and that's something called disparity, that public health professionals around the country have gotten more and more concerned about. My take on that, on what disparity is it's the unfair distribution of harm, risk, challenges, and short and long-term poor health. Some people are burdened with more challenges because of the way our society is set up than others, and as a result have more of an impact on their health. Poverty is to a great extent a community problem of resources rather than just an individual problem. Resources such as affordable housing, transportation, education and training, jobs providing a living wage, health insurance, and available, affordable, quality child care. So how are we doing as far as poverty goes? Not very well. Missoula has a higher poverty rate than both the state and the nation, and it has been trending upward. In 1970, there were 11% of the population in Missoula was living in poverty, and now it's at 16%, and we're all waiting to see what the 2000 census shows us as far as our status right now. One of the concerns is that there's been even more of an impact on children and single moms. Children are particularly vulnerable to poverty for a number of different reasons, and the percent of children in poverty has doubled since 1970, from 10% to 20%. A lot of people living in Missoula find that number hard to believe because they don't see children in this. They don't know that the children that they're seeing are in this kind of situation. And to make that even more powerful, that's 4,700 Missoula children who live in poverty. A concern is that half of those live in something called deep poverty, which is half the poverty rate, and which really just does not provide anywhere near basic needs. Single mothers are impacted even more. At the last census, 65% of the single moms with children under 6, so this is in that vulnerable stage before kids have started school, were living in poverty in Missoula. So looking ahead in maternal child health, we need to continue to be vigilant about childhood immunizations and to work to having all children be immunized at the right time. A concern in Missoula is that we have very few school-based health services, and we don't have many school nurses, and we've had a commitment in our health department to work towards that goal. We continue to work that way. Our Partnership Health Center that we'll talk about a little bit more in a minute it became more and more acutely aware of the lack of dental care availability for all kids, and we're hoping to make some strides in that area. Another issue that some people may not be aware of is secondhand smoke in pregnant women and young children is a major issue. We've done well with tobacco as far as reducing exposure to secondhand smoke in our restaurants and our workplaces, but in people's homes, and especially at vulnerable ages, children are still exposed. Well, of course, every community needs to have a clean drinking water supply. It's a basic need, and probably also a basic assumption that somebody's going to make sure that that happens. We in Missoula are fortunate to have plenty of clean water to drink and excellent streams and lakes for recreation. Our water supply comes from an aquifer. More than 70,000 residents get their drinking water from this reservoir, which was created 10,000 years ago. And as some of the quotes that Ellen showed us earlier, that aquifer, which is sometimes 10, 20, 30 feet below the surface of the soil, is vulnerable to whatever is introduced from above. One strategy that the community has taken to try to protect that aquifer is it created a Missoula Valley Water Quality District in 1993, which gave us more tools and ability to put protective measures into place. A priority over that time has been to extend public sewage and water systems to reduce the total number of septic systems in the valley. Now, this chart is showing you the number of homes or residences in Missoula Valley that are currently on sewer systems. And you see a steady, gradual increase, which is a sign of progress. About 40% of all the homes and businesses in the Missoula Valley use septic systems such as drain fields, seepage pits, or cesspools to dispose of wastewater, while 60% are connected to publicly owned treatment facilities in Missoula, Lolo, and Elmar estates. Sewage disposed of through septic systems contributes pollutants, including nitrates, bacteria, viruses, and parasites to our groundwater, which can pose a threat of isolated waterborne disease outbreaks in areas vulnerable to that pollution. Because all groundwater in the Missoula Valley eventually discharges to surface water, pollutants such as nitrates from septic systems indirectly affect the quality of our Clark Fork and Bitterroot rivers, too. Wastewater collection and treatment protects groundwater and drinking water and provides improved treatment for constituents such as nitrogen. And so this is a goal of the Water Quality District. More than 7,000 homes and businesses in the more densely populated areas of the valley continue to discharge, now this is a somewhat shocking number, 542 million gallons of sewage into our aquifer every year. So looking ahead, in addition to working towards sewering the valley, we want to prevent the gasoline contamination from fuel storage tanks and pipelines. We want to continue to reduce low levels of perc in the aquifer. And a major effort that many of you are aware of that's currently going on is to clean up chemically polluted sites such as Milltown and the White Pine in Sash, and champion the proposal, the Two Rivers proposal of getting rid of the sediments and the Milltown Dam altogether. Another key area in regards to health is nutrition. Nutrition is essential for growth and development, health, and well-being. Behaviors to promote health should start early in life with breastfeeding and continue through life with the development of healthy eating habits. Nutritional or dietary factors contribute substantially to the burden of preventable illnesses and premature deaths in the United States. Some of the diseases that a healthy diet will help reduce are coronary heart disease, stroke, type 2 diabetes, some types of cancer, osteoporosis, and dental disease. At the Missoula City County Health Department, we have several efforts in place to try to improve diet and nutrition. A major program is WIC that is housed at the Health Department. And other federally funded programs in the community are food stamps, school lunch program, and Meals on Wheels, because having adequate food and food security is, of course, an obvious important component of healthy nutrition. We also have innovative efforts like the Garden City Harvest Community Gardens. There's a Missoula Breastfeeding Coalition, and there's a network of emergency feeding programs that are very successful, the Food Bank, Poverello, Salvation Army, to name a few. As far as our status, the important things that I wanted to point out with this is that this is probably a decent indicator in the nature of our diets is how many people eat 5 fruits and veggies a day. Many of you may be aware that that's one of the goals of a healthy diet. Unfortunately, men are doing a lot worse in this area than women. Men are coming in at about 18% have that kind of a diet, whereas women, it's nearly twice as much. Another thing that I was going to point out was there's a direct correlation between more education and better diet, and that correlation probably exists with most personal health behaviors. The more educated we are, the more healthier we are likely to be over time. Now, this is a different concern, and this has to do with how many of us are overweight. There's been a lot of discussion about this trend nationally and that we're getting fatter. The estimate right now is out of adults, 52% of us, just over half of us, are overweight. They have a complicated formula that they use now that if you want, you can get more information, just call us up and how to figure that. But we're concerned about this and see this as something that this health department is going to need to work on more in the future. So, just quickly, 3 veggies, 2 fruits, 6 servings of grain, less fat, and we have a pretty decent diet. Nothing comes close to the impact of tobacco use on health. It's heads and shoulders above every other factor. Everybody knows that it poses significant health risks. 1 out of every 5 deaths in Montana is tobacco-related. Smoking is the cause cited for nearly 90% of lung cancer deaths. There are more tobacco-related deaths than deaths from traffic crashes, alcohol and drugs, homicides, suicides, and AIDS combined. I don't want to spend a lot of time on tobacco because it's gotten a lot of attention, but these are some of the strategies that we have in place right now in Missoula. We attempt to reduce access for underage smokers. There's a lot of different kinds of education efforts to talk about both the dangers of smoking, but also how to contend with peer pressure, those sorts of things. There are efforts to counter tobacco marketing, which is tobacco companies put a phenomenal amount of money into trying to convince us to smoke. We've had great success reducing environmental tobacco smoke with the passing of an ordinance that does not allow smoking in restaurants and workplaces that many of the other communities in the state have been working on since we passed ours. We also have opportunities to quit smoking. There's a program called Quit for Life and several other things to try to make it easier for the majority of smokers each year that talk about and express interest in quitting. But about 1 in 5 adults still smoke. It's kind of hard to believe, but there you go. That's stayed about the same for some time now. The good news is that that's half the rate of where we were at in 1965 when 40% of the population smoked. 7% of our adults use spit tobacco. So looking ahead, we want to further reduce tobacco advertising. Probably the single best way to reduce the use of tobacco is to raise the cost of cigarettes, and there's been work at the legislative level to try to increase taxes and those sorts of things. I don't think we succeeded this year, but we'll keep working at it. As I mentioned before, we're concerned about families and secondhand smoke and are encouraging people to consider either smoking outside in their own homes or choosing different times or places to smoke to try to reduce exposure, especially if there's children involved. Another powerful force in helping reduce tobacco use is if a person's health care provider brings it up when they visit. Access to medical care is a vital component of a healthy community. Given the high cost of medical services, treatment is often prohibitively expensive for those without health care coverage. While some people may obtain medical treatment through Medicare or other government-sponsored programs, many members of our community, in particular females, young adults, and the working poor, have no coverage and do not use medical services because they can't pay. The consequences of inaccessible health care are serious. Wellness care, regular checkups can prevent many health problems. Illness is relatively inexpensive to treat with early diagnosis may, without that kind of intervention, escalate to emergency status and great personal and financial burden later. Lack of medical services also breeds isolation among people who may already feel alone and abandoned. One major effort that's occurred in Missoula has been the establishment of something called the Partnership Health Center, and it's just been a good story and a positive reflection of our community from the very beginning. In 1987, the health department, in trying to respond to this concern, started a small clinic, and St. Patrick Hospital stepped up to the plate and helped a great deal to support that effort. In 1991, there were at least 160 medical professionals who donated time to Partnership for Access, the name of the clinic at that stage, and contributed their professional care to try to deal with people without insurance. And then in 1992, with the help of two critical grants, the Partnership Health Center opened its door, and it's now federally supported as a community health center. In 1999, Partnership Health Center defied the odds and moved into a new building that it helped raise money to establish, and that's where it lives today. Unfortunately, we can't see all the people who need to be seen, but we're doing a lot better than we have ever done before. There's two different ways to look at this concern. One is whether you've got any insurance at all, and that's about 17%, and that's the way it's held for some time. And then the other is whether you're underinsured. And 1 out of 4 Missoulians are considered underinsured. This number is actually a little more conservative than it is for people under 65, because it doesn't show that when you're over 65, 99% of the people are covered by Medicare. Another development in the last couple of years has been a program called Covering Kids, which is helping children get health insurance. So my last category is other chronic diseases and injuries. And I just want to briefly look at a few things. Most of the preventable health risks are associated with personal behaviors. I guess that's good news and bad news. The good news is there's a heck of a lot we can do to improve our health status in the short and long term. And the bad news is that we like a lot of the personal behaviors that we have to change in order to do that. The way a health department approaches these kinds of concerns is with population-based strategies. So we lean less in terms of one-on-one work with individuals and more in looking at how can the community as a whole change things so that we might make it a more supportive environment for people to choose better personal behaviors. I would like to look at just a couple of different issues. One is that the department is focused on reducing motor vehicle crashes for 15 years, which is a major source of injuries. And we're also looking ahead at reducing obesity and improving oral health. Motor vehicle crashes are the leading cause of all deaths resulting from injury. besides personal pain and loss, there are huge health and economic impacts associated with crashes. These crashes happen for a variety of reasons, most of which have to do with people rather than engineering or environmental conditions. The vast majority of the resulting injuries and deaths are not acts of fate, but are predictable and preventable. So you notice this graph to the right shows crashes going up, and it also shows some progress we've made as far as the relationship of alcohol to those crashes. We've almost halved that rate in the last 20 years. But unfortunately, because of those factors that we talked about earlier with air pollution, the total number of crashes are going up, partly because we have a lot more cars on the road. We have more people driving. We've got people coming in and using this regional trade center that Missoula represents. And then, unfortunately, more people drive more each day than they used to. One of the interesting things to look at in this chart is that there's about 2,000 crashes in Missoula County a year. 1 out of 10 of those are classified as severe. Some of the strategies that we have in place as far as traffic safety goes involve technology and safety standards, encouraging people to use safety belts, the development of more effective child safety seats, airbags, that sort of thing. Legislation in which we try to tighten the laws that are on the books. We would love it if the seatbelt law was a primary offense instead of a secondary offense, and the DUI laws have been tightened over the years. Education. There are special enforcement programs where our local law enforcement and highway patrol goes out and finds speeders and enforces DUIs. There are engineering changes that make a difference that reduce the likelihood of crashes, and the emergency medical services is a part of a community strategy so that there's a quick response when there's indeed a crash. Another concern that we mentioned before is oral health. When I refer to oral health, I mean that people have regular dental visits, that their teeth are cleaned, that we reduce permanent tooth loss, that we reduce and treat dental caries, and that there are dental sealants available. And one of the challenges is that many people don't have access to this dental care in Missoula. Another strategy that is worth considering is fluoridation. This graph didn't come out real good, but it basically shows that about half the United States population has fluoridated water, and it's been shown to significantly reduce dental caries. This is a development since about 1945. There's a possibility that Missoula could have fluoridated water and really make a difference as far as people with dental caries and those that can't get to dentists. Will be something that we'll continue to look at in the future. And the last item that I wanted to bring up was physical activity. I think most people are aware that there are benefits from regular physical activity, that we can reduce some of these current killers. Ellen showed a list of the difference between what killed us in 1900 and what kills us now. Well, these are the kinds of things that we are dying from, and regular exercise helps. The goal is really not that tough. We're now talking about 5 times a week of people having 30 minutes of exercise that can just be walking. And the 30 minutes doesn't have to all be in a row. And you think, well, that's not that tough. And right now, about 3 out of 4 report some physical activity in the last month. But you can see that that number is dropping. And then the flip side of that is that 1 out of 4 have no activity at all. And this doesn't represent the number of people that have regular physical activity. So it's a trend that's, along with obesity, that the nation as a whole is looking at and trying to figure out what to do.
So as Greg has pointed out in more specific fashion, the things that are causing premature death today, or causing death today, are different than they were 100 years ago. So to some extent, we're victims of our own success. But as one public health expert has put it, the causes of ill health do not stand still. Society's very progress changes them. And when we look at the causes of death today, we can see that they have less to do with communicable disease and more to do with chronic disease and lifestyles associated with that. In fact, this is from a study in the Journal of the American Medical Association that takes those previous causes of death that we just looked at, which are actually your diagnosis or cause of death at the time of death, what would actually go on your death certificate, so to speak, and it looks at what is the actual cause, what really led to that death, and it's largely behaviors, lifestyles. And the biggest one, of course, as Greg mentioned, is the use of tobacco. 1 out of every 5 premature preventable deaths in this country is related to tobacco use. And then diet and activity, as Greg pointed out, obesity, nutrition, those types of issues. If you just take those 2 causes of death, we have over 1/3 of our causes of death represented in those types of lifestyle issues. Now, these kinds of issues aren't given to regulations, vaccinations, pills, technological fixes. These problems exist where we live, work, play, on our dinner table, and that's where they have to be changed. And this is a real challenge for public health, to come up with new methods for dealing with these issues while still keeping the old plagues at bay. It becomes even more complex when we look at what are the determinants of the population's health, our social environment, physical environment, genetics, how we behave as individuals, access to health care, poverty, physical health, and how functional we are. All are related to our population's overall health. And so it's not as simple as, again, a technological fix or curing a communicable disease. It's very complex. However, while it looks more difficult from this end of it, we do know from history that smallpox, Rocky Mountain spotted fever, and all of the other communicable diseases we touched on were particularly overwhelming at the time. And we do know that some of public health methods can continue to be used to deal with these new diseases: vigilance, science, epidemiology, and changes in society as a whole. What's in our future? I think Greg touched a lot on what's in our future. A lot of what we're dealing with now, and the list of preventable premature deaths pretty much tells us the work that's ahead. But just to give you an indication of some of the more specific issues we are going to have to deal with. We are getting older. We have an older population. We do know that depression is more prevalent amongst older folks. We also know that, more specifically here in the West, suicide is at a higher rate than we see in other parts of the country, particularly amongst some of our younger folks. And we know that depression can be a precursor, in fact, a cause of suicide. So here we have one measure that we can look at, and this comes from our year 2010 health goals from the U.S. Department of Health and Human Services. And we know that science and availability of medicine isn't the entire answer, because even though depression is treatable by modern-day antidepressants for at least 80% of the people that have it, we see that only 23% of the folks that have depression are seeking that treatment or are able to get that treatment. Depression ranks second in our burden of ill health in our society. So public health is more than science. It has to do with access to care. It has to do with changing behaviors. And I think with issues like mental health, it has to do with changing the values that create stigmas. Stigma is certainly a problem that we have to overcome if we're going to do better with our mental health indicators now and in the future. Another is, as the population ages, we're going to have, we have those extra 30 years now. And we have bodies that aren't really yet equipped to live well in those extra 30 years. We're going to continue to see, without intervention, larger numbers of osteoporotic fractures amongst older folks. We look here at what the hip fracture, that the increased mortality that a hip fracture can bring with it, not to mention the decreased mobility and independence and the cost to society. And we look ahead a little less than 50 years, and we can see that just the sheer number of hip fractures, again, if it's non-intervened, is going to about triple. Probably one of the biggest issues that we will continue to deal with in public health, that was an issue in the early days of public health and still will be, is the issue of disparity. I chose this picture because this is the opening day of the Native American wing at what was the Galen State Hospital for tuberculosis care. This was in 1954. The original Galen opened several decades before that, but Native Americans were not allowed in Galen. And so several decades later, a Native American wing was formed. This seems very topsy-turvy and speaks a lot to the issues of disparity and how they produce ill health, given the fact that Native Americans had a higher TB rate than Native Montanans did compared to white Montanans. So the issue of disparity is going to continue to be a problem for us as we try to address the overall health of the population. We really have to look at those that are in pockets of ill health for reasons that aren't always within their control. One of my favorite stories to keep in mind when we deal with disparity and when we deal with the fact that disease is a social construct, that we view disease sometimes as scientific, as sometimes caused by microorganisms. We sometimes view it as caused by the person. We sometimes view disease as somehow being more dangerous if it resides in one person as opposed to another. And this is a picture of Mary Mallon over on your left, better known as Typhoid Mary. Typhoid Mary was locked up for the rest of her life from the health officer in New York City for spreading typhoid. And what's very interesting about that is Typhoid Mary was an immigrant Irish woman. There are documented cases of other non-immigrant males at the same time with the same condition that she had that were not quarantined in the same manner. So this is just something to keep in mind as we go about looking at how are we going to deal with tobacco. Do we view tobacco as negative or do we view the smokers as negative? I think it's real important to keep our values and who it is we blame or who we think is responsible for disease in perspective, and Typhoid Mary has always been a lesson for me on that. We have to remember that stigma and discrimination are enemies of the public health. This very poignant quote from the late director of the International AIDS Center. I think we at the health department and our board has an underlying belief that silence can be deadly, that if we stigmatize people because of disease or we allow discrimination to run unchecked, we will see more disease and we will see more suffering and death. And what we try to look at in public health is to look at the population as a whole. We try to believe and help others believe that the health of some is connected to the health of all. And it's not a very different lesson from thinking we could keep smallpox at bay without protecting the health of everyone. That's the same when we look at diseases that are worsened by poverty. The last thing that we try to remember in public health is that public health is essentially a non-clinical function. It is not health care for the poor. What public health is to work in the field where disease and problems are manifest, where people live, where they work, where they play, where they eat. And so we are largely field workers. And in order to be successful in that, we have to invite the public into what we do as well, because we try to practice on the public's turf. And here's an example of a public health nurse visiting on an Indian reservation. This picture for me talks a lot about prevention. It talks about working in the field. It talks about disparity. And to me, it's just a real good picture of what public health can look like. Finally, we have to look at the health of our health care, of our public health system. And our public health system has not really changed successfully with the nature of changing disease. An important study that came out in 1988 concluded that the nation has lost sight of its public health goals and has allowed the system of public health to fall into disarray. We now have more complacency than we did when communicable disease was more prevalent. Our policies and our methods and our funding are not in place at the level they need to be to truly deal with today's diseases. So one of the reasons we wanted to bring all this information to the public today is the practice of public health affects the people's public health and vice versa. And we think that the public's understanding of what we do and our understanding of what's important to the public is real necessary to improve the practice of public health and the health of our community. So thanks for your interest in our work.